All right, thank you, everyone. And once again, welcome to Trust for America's Health February training for our age-friendly public health systems series. We're going to be focusing this year on our 6 C's framework, our AFPHS 6 C's framework. And the first C that we're talking about today is creating and leading change to support older adult health and well-being. We have 2 wonderful presenters today, Dr. Kina White from the Department of Health in Mississippi, and Dr. Lisa McGuire from CDC, who will be talking about creating and leading change from specific examples of work that they both lead. So Karan, next slide, please. For those of you who are unfamiliar, Trust for America's Health. Oh, I don't think I introduced myself. I am Megan Wolf. I'm a Senior Policy Development Manager at TIFA, and happy to welcome you all here today. So for those of you who are unfamiliar with Trust for America's Health, or TIFA, we are an independent, nonpartisan public health prevention and advocacy organization. We work to advance evidence-based policy. We do a lot of work around advocacy, and all with a focus on equity. We are dedicated to improving the health of every individual and every community, and making disease prevention a national priority. On the screen, you see just a sampling of some of our reports that we publish on an annual basis. And look for the next one that'll be coming out is our Ready or Not report, which will be coming out hopefully next month. Next slide, please. So once again, if you will all please keep your devices on mute during the presentations. We will have an opportunity for questions and answers toward the end of the presentation. In the meantime, if you have some questions while the presentations are happening, please feel free to submit them in the chat, and we'll make sure that our presenters are aware of your questions. Next slide. So as I mentioned, our speakers today are Dr. Lisa McGuire, who leads the Alzheimer's disease team at CDC, and Dr. Kina White, who's the director of the Office of Community Health Improvement at the Mississippi State Department of Health. So we will start with Dr. McGuire, and Dr. McGuire, I will turn it over to you.
Great. Thank you so much, Megan. Next slide, please. So I'm going to provide today a little bit of an overview of how we approach things from CDC from a public health perspective, some of our initiatives, leave you with a call to action. So in other words, your homework assignments, as well as share with you some of our latest news to know for you. So while I'm doing my presentation today, I want you, if you don't have an image of a person who has Alzheimer's disease, I want you to think of my mom here. So she's 96. This was a really good day in November, a very good day. Since then, things are not as good, but she is hanging in there, and she had a very nice Valentine's. But I think it helps all of us to think about the folks that our work is helping to support, their family members, those people who provide support to them in all aspects of their lives.
Lisa, you've gone on mute somehow.
I've been pushing too many buttons, I guess. This is why I don't like to drive my own slides. Next slide. Okay, and one more. So I'm going to talk a little bit about public health and what is that public health approach. Some folks work who work in the healthcare sphere, they work with the public. So that's public health, right? But when we talk about public health as a public health agency, we actually have a public health framework in mind that we operate under. And so with a public health approach, what we are trying to do with our one interaction or our few interactions with people is we try to reach as many people to make the biggest impact as we can. So instead of working with one person at a time, we try to reach many people at a specific time. Next slide. So the way that we see ourselves as a public health agency is we are that bridge that fills the gap. So there's the biomedical research, all the amazing scientific advances that are happening. There's also on the other side of that big gap, There's wonderful services. There's people out there providing respite care, various things through triple A's, other types of services that are available out there through various community organizations. But what public health can do is public health can really be that bridge. It can convene, it can connect, and it can help take that information from that biomedical research and translate it so it can be rolled out into the community so it can help and serve as many people as it can with that great information. Next slide. So within public health, we have a variety of different points of where we can intervene. So I'm talking to you today from an Alzheimer's disease perspective. And so even when we are talking about a disease process such as Alzheimer's disease, there are multiple places that we can intervene in that disease process. And if you'll click one more time for me, please. The first place that we can intervene is through primary prevention. So in other words, this is earlier in the disease process, or sometimes we refer to as more upstream, this is where we are trying to eliminate or to minimize the various behaviors or health conditions that we know that can lead to something later on. So one way if you think about traffic accidents, one way that we can minimize people getting hurt in traffic accidents is encouraging people. Now we have laws to have people wear their seatbelts. And so that reduces the likelihood that they will be hurt. Next click. Through secondary prevention, this is when we are having early detection or management of Alzheimer's disease and related dementias. So in other words, that early detection allows us to be able to plan, allows us to be able to intervene, allows us to be able to treat the whole person and manage many of the other comorbidities that might be going on within that individual. Next click. And tertiary prevention, this is where we also are making sure that we're taking care of people, that they're having high quality of care and that they are safe. So my mother right now, from the perspective of the tertiary prevention, making sure she's in a safe environment, the environment that she was in assisted living no longer was safe for her. So she was not able, she can chew, but she doesn't swallow. She does what I call chipmunk, where she puts the food in the side of her cheeks, or that she didn't have as many people around if she would fall. So we've moved her into a more supportive environment where people are making sure that when she eats, they're checking her cheeks to make sure that whatever's in there isn't in there and that it's actually being able to be consumed. And there's more staff and fewer individuals. So that's one example of this providing, making sure we have safety and quality of care. But also that tertiary prevention includes a lot of other things, such as making sure that we're managing other comorbidities, other conditions that that person has going on in their life, because we want to try to reduce not only those preventable hospitalizations, but other things that can decrease the quality of their life. We want to make sure there's linkages to that care, services, and supports. And we also want to make sure that caregivers are getting what they need as well, too. Next slide. And this I'll leave for you. This is really, I think, a nice reference, but this is showing us really when we think about the sphere, the policy sphere of Alzheimer's disease and related dementias from a public health perspective, we really have only been working since 2005. So that was the first time funding went to CDC, to our public health agency, to start focusing on brain health. But I think as you'll see, man, there's been a lot of activity, a lot of energy, and we really have come quite a ways in a very short period of time. Next slide. One of those big accomplishments that we had for public health is building our largest dementia infrastructure. So this law is very recent, and the whole purpose of BOLD, or building our largest dementia infrastructure, is to create a uniform public health infrastructure across the US for dementia and dementia caregiving. And so it charges CDC with 3 different activities. One of those is to establish Alzheimer's disease public health centers of excellence. And I'll show you in a second some of those centers of excellence that we have. We have one on risk reduction, we have one on caregiving, and we have one on early detection and diagnosis. The second component is provide funding to public health departments across the United States. We know this is where that public health infrastructure occurs. And through CDC funding, we're making sure that people are receiving the funding that's needed to build that infrastructure. The third component of BOLD is also equally important. This is making sure we have data. Data is important for us to know where to act. Unfortunately, within our space, there's so many demands, so many important things that need to be done, but we can use the data that's available to help us make informed decisions of how we can prioritize information. Next slide, please. One more, please. So I talk a little bit about BOLD, but really that first award we had at CDC was for the Healthy Brain Initiative. We still do have funding and we still provide support to external recipients for that Healthy Brain Initiative. The purpose of that whole Healthy Brain Initiative is really to integrate brain health nationally as a central part of public health practice. And one of the ways that we do that, next slide, please, is through our Healthy Brain Initiative Roadmap series. So you see the list of the roadmaps that we have completed. So the smaller two are Roadmap 1 and Roadmap 2. These were roadmaps for state and local public health to really help chart the course for dementia and dementia care within their jurisdictions. The next one, the third one here that you see, this is our current Healthy Brain Initiative state and local public health roadmap. This is the one that our BOLD recipients are working towards helping us implement, and that we are using that as a framework for making that strong public health infrastructure for dementia. Our roadmaps are built on the essential services of public health. You can see a modified wheel up in the top right-hand corner with 4 quadrants there. We are currently revising our state and local roadmap for public health. The new roadmap, Roadmap 4 in that series, will be released this summer. You will see a lot of similarities between the new roadmap and Roadmap 3. The last document you see here was a brand new product for us, and this was the roadmap for Indian country. So tribal communities have Alzheimer's disease and related dementias, they have caregiving, but they operate a little bit differently than traditional public health. Those of you out there in public health are thinking, wait, what is traditional public health? We all operate a little bit differently too. But there's some different interfaces between Indian Health Service and public health and how tribal organizations work. So the roadmap for Indian country, we took a step back and we spent about a year learning, listening, and developing that roadmap for Indian country. We will start this summer, kicking off a revision process for that roadmap as well. Next slide, please. So how I see our roadmaps is I see our roadmaps as really that bridge. So as public health, we have that amazing ability to convene, connect people. But one of the ways that you can do that is you can look at the actions through the Healthy Brain Initiative Roadmap series to help identify ways that you can convene people, coalesce people, get them to come together and think, this is what we're going to solve. This is the approach we're going to take. We all know the analogy of the elephant, and that's really the space we're working in with aging and Alzheimer's and dementia. But we have to have we can only make a difference if we can have little bits that we can impact together. And so maybe one of the 25 action items in our state and local roadmap might be that point, or that one place where you can get a group of partners together to gel behind to really make an impact. Next slide, please. So some of the ways that we're doing our work to really make a difference is through our work with the Healthy Brain Initiative. The Alzheimer's Association has been funding a cohort of individuals called the Roadmap Strategist. And this is, as you can see, in collaboration with NACCHO. So really what this is trying to do, because our roadmaps are state and local public health, And so many of our awardees through BOLD are at the state level and not necessarily at the local or the tribal level. And so with this collaboration of the three organizations, we really are trying to get some more messaging, more information, more people trained in these topic areas that we know are so important through this public health roadmap strategist at the local level. Next slide. So just a couple months ago, we were able to announce our second cohort. I will let you look here and see where our roadmap strategist, so this is a competitive process where people apply in and they do receive some funding, they do receive some training. And it has been an extremely successful endeavor so far that we hope will continue for quite some time. Next slide. The other thing that I wanted to talk about is how I've talked about, we got this Healthy Brain Initiative, we got this BOLD, we got these centers, and we've got these programs. How do they all relate? And one of the ways that we see that they all relate is through what we're calling our Healthy Brain Initiative Collaborative. But really what we are doing is we've got our national coordinators, which is CDC and the Alzheimer's Association. We have our population experts. And now any of these folks on here that I'm listing, such as population experts or topic area experts, these individuals, these groups, these are resources for the nation. So if you have questions, if you want to start some work related to intellectual and developmental disabilities, please reach out to our awardees at University of Illinois, Chicago, or tribal communities, IA Squared, or African Americans or Hispanic adults, please reach out to us against Alzheimer's. Same thing with topic areas, interested in caregiving, call University of Minnesota. If you're interested in early detection and diagnosis, call NYU. And if you're interested in risk reduction of dementia, the Alzheimer's Association is an amazing place for you to reach out to. Next slide. So what these groups are doing is our population, our subject matter experts, we really are listening and learning from public health in general, state, local, tribal health organizations. We're listening to the challenges you have. We listen to the needs that you have. And we are trying to be able to provide information, tools, one-on-one counseling to help you get that information that you need to really help achieve those long-term goals. Next slide. And just as a frame of reference, this is our first cohort of BOLD public health programs. And these were 3-year awards. The next awards, which I'll talk about in a few minutes, those will be 5-year awards. So these are the 23 that received funding at either the core or the enhanced capacity level. Next slide. So Mom's back again. The first photo on the left, this was December of, oh wait, COVID was 20. So this had been December of 19. The next photo was 1 year later. So this was a Christmas photo, Christmas of 19. I'm pointing at slides, you cannot see my cursor. Top left is December of 19. The second was a year later. So, you know, we have all these well laid out plans. You as public health professionals do too. Now, were our well laid out plans, did we ever envision there'd be something like COVID? Where we had a lot of challenges and stress on the public health system, families, relationships, the whole 9 yards. So we've got to keep operating and working the best that we can to go forward with those plans that we have charted, but recognize that we still may have to pivot. And even now that I think we're getting back onto the course of the plans that we had pre-COVID, we have had to deviate because there are various challenges that we're seeing because of the impact of COVID-19 on our society. Next slide. So let's click one more. So here's my news to know. So please, if you're interested in risk reduction of Alzheimer's disease and related dementia, our BOLD Public Health Center of Excellence is hosting a meeting in Atlanta on May 16th and 17th. It is free for you to attend. It will be on CDC campus. So you must register in advance. You will have these slides, right? Megan, just nod. Will they have these slides? So you will be able to access the hyperlink for that. Next slide. We have an A list of summit co-chairs, Dr. Wayne Giles and Dr. Jewel Mullen. who have wonderful reputations, and they have a star-studded packed agenda for you for those 2 days. The neat thing about this register or submit input is if you can't make it to the meeting, but you have things that you want people to consider or want them to think about, please submit it through that, because it's really also a public input option. Next slide. And this is just a little bit more about the Risk Reduction Summit. Next slide, please. Okay, so we do have a funding opportunity for the second cohort of BOLD programs. It does fulfill that one of those components of BOLD that I showed you a few minutes ago. By legislation, we will fund state, local, and public health departments. Letters of intent are optional. They do help us out in the planning process. You can just say, hi, I'm jurisdiction X, and I plan on applying for component 1 or component 2. The final applications are due March 23rd, and that is Eastern Standard Time, midnight. Next slide, please. So here's the way that the new awards are structured. So we are having, we're calling them components. So component 1 will be broken into 2 phases. So component 1 is meant for recipients who really need 1 to 2 years of a planning period. This is where you're getting your coalitions together, your jurisdictional plans together, and you're really getting things rolling. Then years 3 through 5 will be implementation. Component 2 awardees are ready. They may be existing awards of ours, or they may have already a coalition and a plan in place, and they will be prepared to implement from day 1. You can see the award amounts, the average award amounts. These are 5-year awards. We do estimate that there will be 35 or more awards. It really depends on the pool of applications. Next slide. I just want to point out the eligibility. And this is verbatim from the BOLD legislation. So I did say health departments before, but the legislation is a little more explicit. Health departments of states, political subdivisions of states, tribes, and or tribal organizations. The other thing to make sure that you pay attention to is if your application is for a component 1 is over $350,000, it will not be reviewed. And if you're a component 2 application, if it is over 600, it will not be reviewed. The other thing to keep in mind is if you are currently funded under one of our BOLD programs, you are not eligible for component 1. You will need to compete as a component 2. Please note that per statute, there is a 30% match. There is an option for a hardship waiver, and then all that information is identified on our website. Next slide, please. So if you don't get our newsletter, please do sign up. We only send out email newsletters about once a week. We talk about things such as these funding opportunities. We share with you things like who the roadmap strategists are and various other releases and webinars and things that you might be interested in joining. Next slide, please. So I want to thank you very much. And I just want to point out that my colleague, John Sheehan, put in the link in the chat for your registration for the Risk Reduction Summit. So if you do want to attend, I encourage you register quickly. The seats are filling. The auditorium is limited. So thank you all, and I will turn it back to Megan, our MC.
Thanks so much, Lisa, and thanks, John, for putting the link in the chat there. Again, feel free to add any questions that you all may have in the chat, and we will get to them. Lots of information, Lisa. Thank you so much, and thank you for sharing the pictures of your mom. She's precious, and our thoughts are with her and with you as you go through this journey with her together. Okay, so let's go to the next slide, and we will bring up Dr. Kina White from the Mississippi State Department of Health. I will turn it over to Dr. White.
Thank you so much, Megan. And Dr. McGuire, it's always a pleasure to hear your story about your mom. It's so relatable to so many people. So thank you always for sharing. Next slide. So what I want to do today is sort of really share a landscape from Mississippi. We were very fortunate to have an opportunity to be a BOLD grantee as well as an age-friendly public health systems grantee in 2020. And so today I just want to share our journey of how we began supporting older adults through these efforts and some things ahead for Mississippi. And so Mississippi does have a centralized governance structure for our Department of Health. And to Dr. McGuire's point, since we are centralized, a lot of our initiatives, or all of our initiatives actually, go through our state office. Our local units do not have independent autonomy. And so whenever we're working on operational strategy, it does happen at the state level. In September of 2017, our agency became accredited through the Public Health Accreditation Board. I share that as importance because I'll share with you throughout my presentation some of the ways in which our work aligned with our accreditation strategies. Thinking about older adults in our state, we have 82 counties and our population is declining as a whole. However, our older adult population is actually increasing, and we have greater than about 16% of older adults in Mississippi. And as I shared, we were very fortunate to receive funding from Trust for America's Health and the John A. Hartman Foundation to work towards developing an age-friendly public health system in Mississippi. Next slide. So why did we want to create an age-friendly public health system? We looked at several areas and tried to determine what was our current status of need. Our public health infrastructure, we recognized that we needed an increase in workforce to address those who were aging and chronically ill. We also looked at program capacity and sustainability. How are we doing with our older adult programs related to chronic disease and other comorbidities? And also looking at our PSC, our policy systems and environmental change strategies. Prior to receiving the BOLD funding, we had not had a chronic disease program that provided the opportunity for a full public health approach to address dementia and Alzheimer's. So that was very exciting that we were able to increase that program capacity to our agency. Also, we looked at health disparities and health equity. In Mississippi, of our 82 counties, more than half of them are designated as rural counties. So we have significant challenges with those social determinants like access to care, health literacy, low income levels. And so we really wanted to address how we support our older adults who may be socially isolated in some of our rural communities. And lastly, data collection and dissemination. What we identified when we received our age-friendly funding is that there were limited state-based resources that outlined data needs for the older adult population. And so I'll share some exciting work we've done over the last 2.5 years to address that gap. Next slide. So initially, when we received our funding in collaboration with Trust for America's Health, we basically did a scan. We wanted to see where we were as a state in our needs. We did look at the World Health Organization age-friendly framework. We looked internally to see what our strengths and weaknesses were. We looked externally. We also looked across plans. We looked at our emergency preparedness plans, our state health improvement plan. We looked at our state aging, our state unit on aging plan, and several others because we wanted to not be duplicative. We wanted to see what capacities existed and where we could step in and fill a gap. One of the key strengths that we had at the time of our initial application was strong agency commitment. Our state health officer at the time, Dr. Dobbs, was very, very encouraged and supportive of our efforts to pursue not only the initiative, but also the prioritization of older adult needs. And so having that commitment at the very beginning of our work allowed us to have some great success on the front end. Externally, we did work with several key community stakeholders. I'll share who they were in just a moment. But as a note, I would always say as a lesson learned, making sure that you respect the space of those who are already doing some of the work. And so we wanted to ensure that we invited those who had been at the table supporting older adults in our process as well. Next slide. So healthy aging and PHAB accreditation. Once we received our age-friendly public health funding, we recognized that the PHAB accreditation board had actually created healthy aging recommendations of inclusion into the accreditation work. While it wasn't required, they did encourage health departments to look at strategies that support initiatives around age-friendly public health system. And they offered a very detailed working paper that provided a lot of recommendations that we took into account as we began our work in this process. On the slide is a copy of the report But if you'll go to the next slide, I'll highlight some very specific recommendations that align with the 10 essential public health services that Dr. McGuire previously mentioned. So EPHS domain 1 and 5 really looked at those state, community, and tribal health assessment and improvement plans, because what we wanted to do was ensure that older adults were prioritized in existing plans, and if they were not, be able to ascertain how we can include them in that work. Also looking at strengthening, supporting, and mobilizing communities. That is a key domain in public health. As Dr. McGuire talked about partnerships, public health is well known for convening, and in our age-friendly public health space, we wanted to continue in that space. Communicating effectively and making sure that we have timely information is very critical to this work. And so we've put in some strategies to address that as well. And then lastly, having a system that had equitable access. We have found great success with working with our Department of Aging, our Mississippi Access to Care Network. That network is designed to work with our AAAs and planning and development districts across the state. So we immediately invited them to the table as we began doing our work to ensure that we were all communicating to the same target population. Next slide. Early on, as we began envisioning how does public health approach aging in the older adult population in a space that we had not previously prioritized intensely, we thought of a couple of opportunities, and then we invited Dr. Phillips, and we also invited Washington State Department of Health, Marcy Getz, to share some resources related to life course perspective and creating that understanding for not only our internal but external partners of how this approach could be very helpful for healthy aging and really looking at prioritization of older adults. And if you just think about the basic principle of the life course approach, it is just that working across the entire life cycle, looking at more upstream approaches and really looking at how life events and relationships and transitions occur. We are heavily trying to not repeat processes, but really grow and strengthen what already exists. And the life course perspective is a great way to do that. It borrows from the sociology framework, but it really helps to understand how we can mitigate some of these obesity concerns if we take an upstream approach on the front end. So we're hoping we can have more success with the life course perspective in our healthy aging efforts. Next slide. When we began our work, we did invite the Reframing Aging initiative to provide an opportunity of education in Mississippi. One of the questions that was asked when we received the funding was, what does it mean to be age-friendly? Does that definition apply to all environments or only to this work? And what we found is everyone had a different definition of what it meant to be an older adult or an aging adult or age-friendly. And so we had a kickoff webinar. We brought our state unit on aging, we brought our extension services team and several others to the table just to have a conversation about ageism and the impact of health and how it was important for us to communicate in a way that was inclusive of this target population. We had a great response initially to the kickoff webinar, and we really began trying to collaborate at a local level of how we began reframing aging, and not just as a public health initiative, but even working alongside our state unit on aging and asking them those questions and really being able to frame our communication. And that's something that I will say as a compliment is we've been working hand in hand through all of this work. Although public health is working to reframe our system, we work very closely with our state unit on aging for this work. Next slide. One of the first asks of the Age-Friendly Public Health Systems Initiative was for us to establish a learning and action network. This network for Mississippi was an internal network of public health departments that either had a current program working with older adults or they had capacity to support efforts for older adults. And so as you can see, we had a great response of internal staff who were committed to meeting. Initially, we met on a monthly basis to assess what are we doing as an agency, where can we grow, what are some weaknesses that we have, and who do we need at the table for partners. And so it was a pretty wide array of participation, including our EPI team. We had representation from emergency planning and response as we looked at our state medical needs shelters to ensure that when older adults access these environments that they are prioritized. We also had health equity and many others at the table to have these ongoing conversations. Next slide. We did establish an external committee to complement our internal group. This group meets quarterly, and as a really exciting component of establishing our advisory committee, our state health officer, Dr. Dobbs, sent a personal letter of invitation to every individual, explaining our goal, explaining the importance of this work, and bringing them on board. And from the representation, it was very cross-sector. From transportation to Public Health Association, our state medical association. So just really excited to have that participation. And although this initiative has been a 2.5-year initiative, our advisory committee is still going very strong. And so I'll share some exciting efforts that we have coming up very soon. Next slide. So this is a brief highlight or outline of our process of working towards becoming an age-friendly public health system. So early on, Dr. Kay Bender, who is one of our consultants and actually our executive director for the Public Health Association, she recommended us consider using the collective impact framework to develop our statewide work plan because it really did create the need to determine a shared common agenda. And once we provided training to our advisory committee on the collective impact framework, they were very open to using that model. And so we conducted environmental scans, we educated the committee on this work, developed an interview guide, and actually conducted key informant interviews based on the 5 C's at the time that Megan shared. Later, it was of course adjusted to the 6 C's for the age-friendly public health framework. We presented our findings to our committee and our network. We developed a draft plan. We did some revisions, including getting feedback from our state health officer and the public, and then finalized our final work plan. Next slide. So for those who may be unfamiliar with the collective impact process, there are 5 features to it. But one of the backbones was really coordinating across organizations. That was a key strategy for our work, is really coordinating across not just public health, not just State Unit on Aging, but having academia, having the healthcare system and many others, and creating that common agenda for change. We did have 3 phases of work that we're working through. Right now, we're actually in phase 2. We've developed our work plan. We've mapped out some of our landscape, and we're now moving into those infrastructure and really engaging our community and the public and doing some of this work and identifying those key champions to help us continue in this effort. Next slide. So here are the results of those individuals who participated in our key informant interviews using the collective impact framework. We had our agency senior leadership, we had our academic medical center, and many others be involved. And one thing that I'll share, Dr. McGuire mentioned caregivers. Caregivers are a significant part of our work. And so we also engaged with caregivers to get feedback on our work plan because we wanted to ensure that we were inclusive of their needs as well. Next slide. So the theme analysis for the 5 C's initially didn't have a perfect fit to our group. And so when we looked at the use of regulatory programs, especially long-term care facilities, initially those 5 C's didn't encompass everything that we needed to have. So we thought about financial security for the aging population, as well as those environmental systems change. In the midst of us completing our analyses, Trust for America's Health came out with the revised framework. Mississippi likes to say we take credit for TIFA adjusting the framework because it was perfect timing that we shared there wasn't a perfect fit with the 5 and then came the 6. Next slide. So the initial 5, one of the strongest areas of consent that Mississippi has was data. We identified that data was a significant need in our state. We did not have enough data related to aging, specifically in Mississippi. We understood convening and working with stakeholders and coordinating resources was important, but the need for data stood out very significantly from our team. And then also looking at augmenting existing services, our informants agreed that there are challenges, but we were very unsure of how to address those challenges at the time of the initial interview. And so we put some plans in place to really be able to question the availability of these resources and how we can augment them for older adults in Mississippi. So I'll share how we were able to accomplish that. Next slide. You have to probably click it twice for the infographic. So one more time. As a part of our effort, we did create an infographic. Our advisory committee was able to develop a vision, values, and principles in Mississippi for our work. At our Public Health Association conference last year, Trust for America's Health, Dr. Phillips and others came along, and we were able to release and share this infographic as a first step of really educating the public on our age-friendly movement for public health in Mississippi. We were so excited to do this, and we received a lot of positive response, but it allowed our community to understand sort of the needs that we have and what are these key principles to do this work in Mississippi. So that was a very exciting transition from just strategy and building capacity to actually now engaging our community. Next step, next slide. So when we made those revisions to the work plan, as you can see now, those 6 C's, creating and leading policy systems and environmental changes was the additional C that was added. And with our leadership support, those PSC strategies really aligned with the need for the financial security, the long-term care, and other resources. And so if you'll go to the next slide, here is one piece of our work plan. Our work plan has the 6 goals that align with the 6 C's. It has our strategy, our action steps, and our key indicators. And what we're really excited about is we have an upcoming summit, and we'll actually be doing a call to action to identify those key community champions that will help us implement this work plan. One of the new initiatives that we've been able to collaborate with our state AARP chapter is identifying healthy aging champions. These are retired public health professionals. Many of them are former senior leaders from public health, as well as community agents. They have all voluntarily agreed to serve as healthy aging champions, and they will be able to help us at a local level implement many of these strategies across the state of Mississippi. So having their expertise is an invaluable model that we can have at the local level to do some of this work. So we are very excited to have that collaboration with AARP to do that. Next slide. One of the ways in which we are trying to think about sustainability in Mississippi is not just having an age-friendly public health system, but truly building an age-friendly ecosystem, aligning many different entities to address the needs of older adults. And so I'm excited to share that through our efforts of public health, I've been able to pull along several colleagues, and we're now beginning to develop an age-friendly ecosystem in Mississippi. For age, if you'll go to the next slide, I'll more specifically share who they are. So the shared characteristics of the ecosystem are here. And this is more so just for consumption purposes. It just gives a snapshot of all of the characteristics of being in a public health system, an age-friendly health system, age-friendly community, age-friendly employer, and age-friendly university. And I know the slides will be available later because it may be small for you all to see. Next slide. But here in Mississippi, it looks like our slides are slightly out of order, Dr. Phillips, because they're actually flowing a little bit different than how I had them. Can you go to the slide for age-friendly Mississippi? Okay. So age-friendly Mississippi, as we're bringing our stakeholders together, we are working with our CDC Bold Alzheimer's program that Dr. McGuire mentioned. We're collaborating with AARP and MPHA, our Mississippi Public Health Association, for our Healthy Aging Champions. And we've actually been working on a sustainability approach in collaboration with our Building Resilient Inclusive Communities program. There is a specific component for social connectedness, and we have identified that our older adults are very much isolated in our state and across our state. So we're collaborating with our BRIC program to really see how we can sustain some of the efforts through that project. We are working with Brown universities and their More Than a Meals evidence-based program, and we're also piloting an initiative where we can work with our meal delivery drivers on some social connectedness strategies. And we're also using the UCLA loneliness assessment as well within one of our planning and development districts. In collaboration with AARP, we're also beginning to establish age and dementia-friendly communities. In Mississippi, we currently only have 5 designated age-friendly communities, and so we're working with them as we begin to have new age-friendly communities. We will also work to have them become dementia-friendly as well in response to our BOLD work. We are collaborating also. We have a great partnership with our regional director for Alzheimer's Association. We're working with her to help establish age-friendly health systems across our state, and also working with those health systems to help them have geriatric ED accreditation. And then we're also working with Mississippi State University Extension Services as they pursue age-friendly university designation. So we're just really excited at a local level to have all of these key partners at the table to make Mississippi become more age-friendly. If you'll go back to the slide with the data report, I'll share that one next. So the culmination of all we've been doing, we've realized that data is a key missing element in Mississippi. And we are so excited to share that we will be releasing our first healthy aging data report in just a couple of months at an upcoming meeting. We established a great partnership with the University of Massachusetts, Boston, and they were able to create not only the 82 county data profiles, but a very robust report for us with the health equity lens, looking at how we can best support our older adults. It includes our BRFSS data, our chronic disease indicators, and some demographic profiles. And so we're just really excited to have this capacity for the first time in Mississippi. Next slide. So we are excited to share that Mississippi has achieved 10 out of our 10 recognition steps finally for the Age-Friendly Public Health Systems program. And so we will officially be applying for recognition as an age-friendly public health system. And a lot of that has just been hard work in collaboration with Trust for America's Health, with the John A. Harfa Foundation, with AARP, and many of our other key community partners. So we're really excited to say that Mississippi has made that great progress in just a very short period of time. Next slide. So what are the next steps? We are excited to host our first ever age-friendly public health systems Healthy Aging Summit in Jackson. Since May is Older Americans Month, we are having it on May the 4th in Mississippi. We will have national, state, and local speakers, including Trust for America's Health. We will officially release our report and our data profiles, and we'll have training sessions as well. But how do we keep this going? Dr. McGuire said, what's our call to action? We'll disseminate our data and implement the work plan. We'll continue to be a part of the National Learning Collaborative through Trust for America's Health. We now sit on the Department of Transportation's Interagency Transportation Committee to support access for older adults. I'll continue to lead stakeholder engagement for the ecosystem, and we'll just continue to seek opportunities to do this work, including things like the BOLD program and others, because we just think it's a great way to support the older adults in our state. So there's a lot more to come, but just wanted to share a snapshot of some of the things we've been working on for the last 2 years. Next slide. And none of this would have been possible without some great, amazing people. So just want to give a special thanks to Trust for America's Health, also John A. Harfa Foundation with Dr. Carmody. My CDC BOLD project officer, Laura, has been very helpful in helping us align our Alzheimer's dementia work with our age-friendly work. Dr. Bender at the Public Health Association, Melinda with AARP, Marcy is my peer in crime for age-friendly public health, as Washington was funded at the same time as Mississippi. And then just our state advisory committee, who has just been a great resource of guidance as we do this work. Next slide. Thank you so much. I'll turn it back over to Megan.
Thank you, Kina. Gosh, such wonderful, wonderful work. Great spread of all the work that is really creating an age-friendly ecosystem in Mississippi. So I'm going to turn now to my colleague, Dr. Karan Phillips, also with TIFA, who's going to lead the Q&A session. And Karan, if you want to take down the slides for now, I think we can go to see everyone's faces. And if you have a question, feel free to go off mute and ask your questions.
Thank you, Megan. I'm going to pull up 2 questions that we received in the chat. So the first one, I think this is for both of you, but feel free to comment. How can public health practitioners use the BOLD grant to advance other healthy aging activities?
Kina, I'll let you answer
Sure.
that one.
So I can start. One way, public health is a convener, but I definitely think what we've been able to do in using the BOLD grant to engage others is to talk about this risk reduction piece. Risk reduction is so important, and we have had a great opportunity to engage with our chronic disease programs by simply talking about lifestyle management. In the same way that you can protect your heart, in the same way that you can protect and address hypertension or blood sugar, you can help to protect your brain. And so that's been a way for us to engage with many of our stakeholders, is we use the BOLD program as a way to show that we're not competing for space, we're sharing the same space and we're addressing the whole person. So really looking at that healthy aging approach, we've been able to use the BOLD program to break into conversations that otherwise we were not able to be a part of. So we just really look at it from a lifestyle management perspective. In the same way we want to protect every other part of our body, our brain is the central organ and we want to protect that too. Dr. McGuire?
Yeah, excellent, Dr. White. That's really what I was thinking too, because I think risk reduction provides that opportunity. Because if we think about, like, some of the data shows us, like, when people managing their hypertension, we find that younger people, like 20s, 30s, and 40s, aren't that concerned about heart disease. Now, we're not saying we're not going to make any judgment, but if we say that managing your hypertension can help protect your brain, they're more likely to manage their hypertension. So part of it is, I think, also thinking about, that earlier age groups and thinking about these messages of these good, healthy behaviors that we want people to engage in. And if some 20-year-olds are doing it for their heart, if some 20-year-olds are doing it for their head, that's great. So I think this risk reduction is definitely one of those places that we can look across the whole lifespan, because those behaviors are going to help you reduce your risk of dementia, are also going to help you age more healthily or more longer.
Thank you both. I was not trying not to nod my head too much. I was like, yes. So second question, are LHJs, local health jurisdictions who have received funding through a different Healthy Brain Initiative grant eligible to apply, this is on Zoom, eligible to apply for the new BOLD grant if they are not specifically an awardee of that program?
I can't comment on eligibility. I would encourage you to look at the eligibility section in the notice of funding opportunity. And after you read that, if you have questions about specific eligibility, I would encourage you to submit it through our NOFO mailbox. But according to statute, states, political subdivisions of states, tribes, and tribal organizations are eligible by statute. Okay, Ron?
Thank you. So those are all the questions I see in the chat, but we welcome you to come off mute and engage with our speakers if you would like directly. So anyone that would like to just wave a hand or come off mute. And Barbara, I see you off mute.
I sent a question to Lisa specifically because I wasn't quite sure how to do this. But in the beginning of your presentation, you talked about peer support, and I was kind of confused on what that and how that is addressed.
And Barbara is with the Northwest Washington Indian Health Board. So just so you all know where Barbara represents in the state of Washington. So.
Well, was that in the context when I was talking about my mother and talking about COVID and?
No, it was on one of your slides, you indicated peer support. And I just thought that was an interesting note that maybe people with dementia or older adults are providing peer support to each other. So that's how I
But
read it, and I was confused.
Yes, thank you for asking that clarifying question. So with the peer support with our awardees, what we are doing is the awardees are getting together and we're doing some peer-to-peer learning from that perspective. So like, for example, like when Dr. White does these presentations, we learn all the great things in her lessons learned. And this way, our awardees can talk to each other and learn from each other with that.
Okay, that makes much more sense.
Yes, it does.
Yes, it does. The other question I have is that we are going to be looking at trying to collect some data on I have 6 tribes and we're going to do a survey. And I'm working on the questionnaire right now, but trying to figure out how to use the age brackets and ask them to fill out a box, because when I look at CDC data and they report data in blocks of like 50 to 64 and 65 and older, and a lot of tribal programs recognize their older adults at the age of 55. So I thought, do I break it down from 55 to 64, then 65 and older, for sakes of how we could compare when we're looking at data around slips, trips, and falls? How do we compare with the rest of the population is an example. And if I don't have good data, then I can't say there's more older adults falling and it's a greater risk, and then how to develop assessments. So right now I'm just trying to figure out the boxes. Is it, and so do you have any recommendations?
Yeah, I'll give you my thoughts on that. So you're wanting to not just have a blank where they fill in their age? You're wanting to have them pick a category, or you're wanting to?
So we can put their age as of today, but really I'm not, I can do that, but in terms of putting it in a block or a box.
Okay, for the actual questionnaire.
Yeah.
Well, my suggestion would be I'd ask them to report their age of today.
Okay.
And then when you do your analysis, you can make the decision of which cut points make the most sense for you. So
Okay.
if you're comparing with other analysis that maybe CDC's done that's using a 65 cut point, then you can look at your data that way. Versus if you're looking at some programs that you guys are doing and 55 is the important marker for your information or the story you want to tell with the data, then you would be able to do that. So I would use it as a continuous variable, and then you can categorize it in your analysis depending on what analysis and what message you're trying to get across.
Okay. Thank you.
That was fun to talk data.
Lisa, you're speaking my heart language. I was like, ooh. we had a very good discussion recently with Kathy Greenlee, the former Assistant Secretary on Aging, and she had a very good reminder for all of us that when we talk about 65 plus, we're talking about a lot of different brackets. So a lot of times we're, and we used to talk about this in grad school. So it's considering 65 to 74, and then 75 to 84, and then 85 and older. I mean, even then you could probably still break it down even further, but to say 65 and older, you're trying to generalize a lot into one bracket. And
I agree.
And we talked about 65 and older people are still working. They're the caregivers to the 85 and older population. So that's a great question and great.
No, it's a great, and it's going to also, I think it's really an important question, but it's not an easy question either, because somebody was talking at the very beginning today about how do we define aging or an older adult population. It really just, it boils down to who you ask and what their purpose is for why they've selected it. But I think the thing that's going to be challenging, and this I think is important for all of us who rely on national data sets, is, in an effort to respect the privacy of the recipients, a lot of the age groups have been collapsed. So at like 80 is the cap. So there might be people in the study that are 89, 85, but we can only look at 80 plus. And even that 80 plus range, there's a lot of variability. I mean, my mom at 80, she was out mowing the lawn, pushing a lawnmower. So, there's a lot of variability, and no matter what age group we pick. So yeah, it's a hard question. I wish there was an easy answer to it.
Well, thank you for sharing. Well, we are at the hour. Thank you all for attending. If you have any further comments or questions or thoughts, please feel free to email us. I'm going to share my screen one more time to close us out with just some reminders and some notes. So our next training will be on March 16th, and we're again continuing on with our 60s framework, and we'll focus on collaborating and convening. This will be available to register for this under our events, and it's also shared in our newsletter. For those of you that registered, you had the opportunity to opt into our newsletter, so thank you for that. And to close this out, if you are viewing this as a recording, please click on the right-hand corner or pause the video and navigate to the following link to indicate that you attended this training. Again, this is only for people that are viewing this as a recording, so pause the video and document that you've attended this training. And we thank you all. And again, if you have any questions or want to get in touch with us, this is our contact information. Thank you all for attending.
Many thanks
thank
to our speakers. Thank you, Dr. McGuire and Dr. White. You all are tremendous. Thank you for all of our participants. Great questions, and we look forward to connecting with you next month.
Thank you all. Bye-bye.
Thank you.
Thank
Bye-bye.
you.